last minutes.
So moved.
All right, and a second.
Second.
All right. So a yes on those.
Yes, yes,
Sure.
yes. That's all four of us agree, so it is approved. And we can go on to the reports, and we'll begin with clinical operations. And Dr. Techie, thank you.
Thank you. Thank you so much for having us this morning. Albina and I are very excited to present today on our GME updates. Albina, do you want to introduce yourself?
Good morning, everyone. This is my first time, so I'm a little nervous.
Doing great.
So I'm Albina Shkolnik, Senior Director in Clinical Operations. I've been with H&H for almost 20 years. Started at Coney Island Hospital. My background, as you can hear, I'm an immigrant. So I came here when I was 16 from Moldova with my family.
Great. Welcome.
Okay, so first slide, please. All right. So what we're going to be presenting today is our updates over the last several years in our GME enterprise. So GME stands for Graduate Medical Education, and it includes residency programs and fellowship programs. And the background to this presentation is that several years ago, Congress authorized new GME positions funded by Medicare to address national workforce shortages for health professional shortage area hospitals. Many of our hospitals qualify as HPSA sites, and we applied in each round, and those applications were led by Albina and team. So the punchline is that we have secured 75 slots across these rounds, and we're going to now be applying for the fifth round for an additional approximately 20 slots. This will impact multiple facilities, multiple specialties, and it's part of our broader strategy to directly sponsor more training programs, because this has an impact on the pipeline of the workforce, which is something our office is responsible for and very committed to. In addition, it has an impact on retention of existing staff. A lot of faculty or physicians do want to be part of an academic program and be faculty. So this is really part of a broader strategy, and not to mention there is some funding associated with these slots. So the good news is these awards are permanent. They support expansion of ACGME accredited programs, and it aligns with all of our strategic needs. Next slide, please. I'll give this overview, and then I'll let Albina take over. So the enterprise as it currently stands is that we have 2,900 trainees across H&H in 349 programs, of which 60 are directly sponsored by us. The rest are sponsored by our academic partners and other institutions. And last fiscal year, this enterprise brought in a significant amount of revenue to our hospitals, $592 million, from both Medicaid and Medicare sources. The majority is Medicaid, but the Medicare source is also attributed to these slots. And all in all, we host one of the largest public GME enterprises in the United States, which is something we should really be proud of and continue to support and grow. Next slide.
So I'd like to start by taking a moment to explain what we mean by Medicare-funded CAP slots. Medicare supports training through two funding streams: direct medical education, that covers trainee salaries and educational costs, and indirect medical education, that supports higher cost of care in teaching hospitals. When we use term CAP, we refer to the maximum number of resident and fellow full-time equivalent positions that are eligible for Medicare funding. So this does not mean that it's a maximum of residents that hospital can have, but rather it means that it's a maximum of positions that Medicare will fund. So our goal is to maximize direct medical education and indirect medical education CAP slots, because by increasing it permanently, we increase federal funding and support system-wide growth of our programs.
Can you tell the board what the difference is between the two, the direct and the indirect?
Of course. So direct medical education supports trainee salaries and educational expenses, and in turn, indirect medical education covers higher cost of care in teaching hospitals,
But not the educational expense.
not the educational expense.
Okay.
So correct, Dr. Katz. So another great feature of cap slots is that they are flexible, meaning once awarded, they can be shared between programs within a facility, also between hospitals within H&H, as we have a shared agreement, and between H&H and also other institutions that we partner with. So from fiscal year 23 to fiscal year 26, we have been awarded over 70 Medicare-funded cap slots across primary care, surgery, and other higher need specialties in medicine and behavioral health. Over that 4-year period, our highest investments were in psychiatry with 19 slots, internal medicine with 17, surgery 11, followed by primary care 7, and also targeted expansion in emergency medicine and OB/GYN. These federal awards helped us establish brand new residency and fellowship programs as well. Can I please have the next slide? Whoever. Thank you. Almost done. The strategic impact of these awards is significant. So these awards support sustainable long-term training program growth with associated federal funding, strengthens workforce pipeline, advances health equity and access to care. There are a few key takeaways for the board. First, CMS Section 126 and 4122 awards are permanent, which is important. Second, FTEs are flexible and phased in over time, and that allows us to align growth with operational readiness in each facility and system-wide. And third, our success actually depends on collaborative long-term planning across clinical, academic, and finance teams. In conclusion, looking ahead, I'd like to say that we will continue to transition select programs to H&A sponsorship, expanding our sponsored GME portfolio, and we will align with workforce needs, accreditation standards, and system priorities. I would like to thank all of you for your support and leadership.
Thank you. Questions?
Do
Jose?
do you expect the awards to continue growing in the future, or does it end, does it basically flattens now?
So there's one more round of CMS funded slots that we can apply for, which we are actively applying for. The deadline's the end of March. There are no currently proposed or announced future awards from the federal government. So this is really our last chance for now. There may be further opportunities in the future. We're just not aware of them yet.
It has more bipartisan support than other kinds of healthcare funding, so that's a good thing. Also, I think you taught me something that I didn't understand before. One of our goals is to create a family practice residency. But I understood that until you have the residency, you can't apply for slots because you're not a residency yet. But from what you're saying, we could borrow slots from the same facility or across the department. So if once we created the family practice residency, we could decide that it's worth our putting some of our slots to it to pay for it. Is that's accurate?
Yes,
It is
and actually, if I can expand on that, we actually currently do have a surplus of IME slots across our system, and we do share that between facilities because some of our facilities are over their slots, so we take from sites that have a surplus and share it with those other sites, and we also share it with new programs. And furthermore, we also receive some slots from some partner facilities, and then we give slots to other facilities for an exchange. So there's kind of which I think I mentioned, there's a marketplace in these slots.
Right.
We try to consolidate the marketplace internally as much as we can so that we can grow internally, but we do have additional slots from site to site that we have transferred all over the place, and it's really helped us maintain maximal funding and sustainability.
That's great.
Yeah, my sense was with new programs, for example, if we get a family practice program started, because we don't have any in the system currently, right? Aren't there slots associated with that, or would we have to borrow from our already approved slots? Do you know offhand how that would work?
Yeah. So two things. One is that we can certainly borrow from our current. We don't currently have slots assigned to that program because it's not yet ACGME accredited, so we can't apply for these slots. These require that the program already be accredited. However, what we can do is, like you said, borrow from internally. So for that program, for family medicine, for example, one of the ways we're modeling it is that we are borrowing IME slots from the surplus that we currently have. We do not have any surplus of direct GME slots, so we can't borrow from that.
And there are family medicine residencies, I guess, within our friendly group of people. I know Downstate has a family practice. So I'm just curious, have we utilized that at all, their program, and how has that been?
On the family medicine side, we're working with others that have a lot of experience setting up programs like this. So we're, I don't want to speak too soon, but we're on a good path to finally have our first ever family medicine residency program. Once, to Mitch's point, once it gets accredited, then we'll be able to, use the actual
slots as
the slots as they
do you have a
currently
site
exist.
right now where you're thinking mainly of, or
We do.
going too far? Sorry.
We do, and I'll tell you why we're excited about it, and I'll tell you later about the particular site. In internal medicine training programs, only 1 out of every 5 people, if you're lucky, will go into primary care. In internal medicine primary care training programs, 1 out of every 3 people go into primary care. Still 2/3 don't. In family medicine, almost everybody goes into primary care. So this is a great direction for us. To Sweet's earlier point, a great way to recruit what we need, good primary care doctors. We have a site with the family medicine department that we're looking at now, and we look forward to sharing more with you very soon.
Sounds perfect. No further. And as far as recruitment issues, of the slots we have approved at this point, again, I know you've moved them around, which is great, but as needed, but do we have any issues with recruitment at this point as far as getting, I guess they still use the match these days, is how we get them. Do we have any issues not being able to fill slots, or are we pretty good at this stage at whatever slots we have, being able to attract hopefully good candidates to the slots? Do you know offhand?
Yeah, I can answer that in a couple of ways. One is that we do have really good success filling our programs. I think people really want to train in New York, and they know that our programs are good training grounds. Secondly, I would say that because we are open to foreign grads, I think that also helps us recruit from a diverse group of people, which has really helped us. In terms of not being able to fill slots, I have not heard that from all of our GME partners and our DIOs, which are the designated institutional officials, who are the leads of the GME program at each site. And we do meet with them pretty regularly. So I'm not sure that that's a problem for us. But
Super. That's
I
good to
think
hear.
we don't 100% make the match, but almost always
Outside.
identify outside of the match to fill the programs.
And last question I had is related to the faculty that's needed. Of course, faculty that is dedicated to teaching, of course, likes to have their non-teaching duties pushed aside, which is part of the additional cost actually that goes on in these things. But do we foresee that we would need additional faculty, or are we just going to be able to rearrange internal faculty as far as being able to accommodate the additional slots?
So every program has its required ratios of faculty to residents. So if we haven't met that ratio with our current faculty, we do need to grow. So we do have some programs where we will hire a program director a year in advance of that program starting, because we need that person in place in order to grow. And then in other settings, we have somebody identified who can serve as the program director before the program's up and running. So we have both ways, but we've supported the faculty hiring at multiple sites just in the last few months in order to grow programs.
And in theory, of course, that's where the additional funding can be helping
right.
to cover the costs.
That's
so
right. That's
so
what
that
the IME funding
certainly
is really
helps
helpful
that.
for.
Excellent. Other questions or comments? Otherwise, congratulations. I mean, to me, I don't know how much people understand that is a really major thing, to be able to get additional slots. They've been carefully guarded over the years, and it's great that you're able to
Thank
get
you,
them.
Albina
So
and our team for
thank you,
doing that.
Albina.
The whole
Thank
team.
you.
Yeah.
Super. Thank you. All right, and next presentation.
So I'll introduce the next presentation, somebody who we all know very well. Dr. Wendy Wilcox, our Chief Women's Health Officer, will be presenting her update on a new fetal monitoring project for the enterprise. Take it away, Wendy.
Thank you, Dr. Techie. Good morning.
Morning.
So we're really excited in maternal child health to be able to announce that PeriWatch Vigilance, which is a fetal monitoring program, is finally coming to New York City Health and Hospitals. It's going to really help us give improved and safer care to both our moms and our babies. Next slide, please. So we know that in OBGYN and also in just healthcare in general, there can be some hidden threats to patient safety. These vary from team dynamics, such as, missed communication, failure to escalate, being busy doing other things on the floor and missing cues, fatigue, burnout, many different things can contribute to an environment that really doesn't optimize people recognizing early warning signs for mothers, which would be changes in vital signs and also changes that can happen to the fetal heart rate tracing, which, if things aren't recognized and go on over time, can lead to outcomes that we really don't want for our babies. Next slide, please. So PeriWatch Vigilance is a software system that will interact both with our existing Philips IntelliSpace fetal heart rate monitoring system as well as our Epic EMR. It is a tool that's really designed to give visual alerts to our teams and to make it easier to recognize when maternal vital signs are worsening and or when the fetal heart rate tracing is worsening. It offers basically something called a hub board, which you'll see in a few slides later. But on this board, the whole clinical team will see in different spaces in the labor and birthing units, as well as postpartum, a board that will bring up worrisome vital signs to the top and allow everyone on the team to help, basically keep watch and notify each other of things that need to be addressed. It really also will help in terms of sign out of various teams to another, because it really does allow for some views that will assist in communication. Next slide, please. This is an example of the hub board, which I talked about. And what's really interesting is that although what you see here is static, this board continually updates, and the patients with worrisome signs and or fetal heart rate patterns will rise to the top. And so it is a dynamic board where people can say, oh my. And obviously, I'm sure we all realize that red is probably not a good thing, right? So the red's on top and yellow. Orange would be the next stage. Purple is interesting. Purple is what they use for something called tachysystole, which is too many contractions in a short period of time, which for our patients who are being induced on oxytocin would alert the nurse and the team that they need to reduce the amount of oxytocin or do some other resuscitative measures to help the mom and the fetus get some more oxygen. And so on this hub board, they're placed in prominent places on the unit, as well as people can pull them up from other individual computers and see it, as well as our ORs. It really just, they intentionally did not include audible alarms, and that's very good because people know about alarm fatigue and people turning off alarms, etc. So it really does focus very heavily on the visual cues.
Is there someone who's actually monitoring on a regular basis, like a nurse at a station, or is it basically just available?
I am so happy you asked that. Thank you. So, many of the systems that we toured to see how they are using this software have, after the fact, created a central monitoring system where a group of highly specialized nurses, mainly who are certified in fetal heart rate monitoring, do watch over the entire system and are able to communicate with teams on the floor. So this is stage 2, actual implementation for all of our sites of this system. We just finished our walkthroughs actually 3 weeks, the past 2 weeks. Went to all sites and walked with the vigilance team to see where all of these things should be placed. But we are actively pursuing that would be stage 3. Thank you. And thank you. So this is the single patient view. So this is really helpful um, for our nurses. And what we are making sure is that when they are in the room with the patient, they have a dual stand of monitors so that one monitor can keep the EMR where they can actively document, and then the other one can have this single patient view. What's interesting is that you can see the actual fetal heart rate pattern on the top. In the middle, you can decide how long a view you want to look. So at sign out, you probably want the 12-hour view, right? To tell your oncoming person what's been going on for the past 12 hours. If you were worried about a specific area of the tracing, you can take that timeline down to 8 hours, 4 hours, 15 minutes, and look at individual sections, and then it will show you only that section as well as the color that's corresponding to it. As you can see, on a normal basis, fetal heart rate patterns do go through various cycles, and really that's why it's sometimes very difficult for the clinical teams to really ascertain accurately what's going on. And this is really helpful because, as you see here, there's green, which is good. Then there's purple, which is tachysystole, so something needed to be done to the patient's induction. And then there was a little worrisome yellow period. And so what you don't want is for those yellows to turn to oranges, to turn to reds, and then to have to intervene at a time when it's sometimes too late. Next slide, please. So this is our timeline. As you can see, it's been a labor of love. We really did involve the entire OBGYN council, our physicians, midwives, nurses. Everyone went on this journey together. We had pretty much a full year of looking at all of the systems available on the market, really evaluating them, culminating in an in-person meeting. Every site had 2 representatives. Tried to make it as fair as possible, and Peregrine Vigilance was the winner. And then all the other steps that we had to take. So from this year, we have a schedule of implementation. North Central Bronx will be our pilot site. It's nice because it's fairly small, and it will enable us to really see how the team is working with the software, work out any kinks, and then there's a schedule for rollout. And that schedule also includes timed learning sessions for both our nursing teams and our super users, and then a shorter educational session with our provider teams. Thank you. Next slide. Oh, and that's it. Thank you very much.
Thank
and
you.
thanks to everyone who helped.
Dr.
make this
Martone,
possible.
question?
Yes, hi.
Hi, good morning.
So great. I love the Vigilus Hub. Could you just share with us the from triage to when they actually get a fetal monitor on them? Like, have we looked at our timing on that? And does the board take into account, because I was trying to see and I couldn't, like when the moment that patient checks in, does it take that into account at all? And like the moment you get I mean, obviously
Yes.
once you get a monitor on them, it pops up there, but like,
Yes. So there is a small delay between what Philips pick because the vigilance is reading what's on the Philips and Telespace. We are
Okay.
keeping Philips and Telespace. So that is the tracing of record. And so patients are put on monitors when they enter a triage room and are assessed, by the nurse. That's our point. And then pretty much a few minutes after that tracing is going, then PeriWatch Vigilance. So this will be in all of our triage rooms, all of our labor and birthing rooms, in our ORs, as well as on the postpartum suite for the maternal vital signs, as well as our postoperative areas,
oh, that's
our
awesome.
yeah,
Yeah, thank you.
our PACUs. Yeah.
Questions?
Oh, wait, I'm sorry, one more question. If, I don't know, I mean, just from memory, because of what we've heard in the past, right, some things. If, let's say, a patient has to be housed in a different area of the hospital, are you also able to have this technology apply once they get the?
That is an excellent question. I'm so glad you asked that. Thank you. Yes, there are mobile carts available that can tie into the central card, and we are looking
Prepared
to get that. The one caveat I will tell you is that this has to have, because of the way this is being implemented, which is basically is an overlay of Philips. It has to have an actual computer assigned to it. So we are working with our IT teams to ensure that that happens. So the mobile cart would not just need the mobile, the mobile fetal heart rate monitor, but it will also need a mobile computer to go along with it. So we're looking toward doing that. But we have tried to pay special attention to our emergency departments and like the ICU.
I mean, or anywhere, just anywhere, right? Like, are you building it just for those other departments, or are you considering it being when we're using the word mobile anywhere in the hospital?
Those are the most likely places for people to be when people are and when patients are admitted. I know what you're saying, and we would have to probably move the mobile cart to another area to make sure that it would work. We're really we've discussed this, and the most likely places for patients who would need monitoring off of the labor and birthing suites are really the emergency department and or the ICU. Our antepartum patients in some places are on the labor and delivery unit anyway, and in some cases are on our postpartum units. So in our postpartum design and implementation of Paragen, we have included those antepartum beds to feed into the central hub in labor and delivery.
I appreciate that response. Thank you. But this brings up a concern for me because I remember something, if you guys remember something, okay? Like MedSurg might be a possible location as well. And that's why I'm asking if we're making it mobile, could it just not be mobile for anywhere in the hospital? Because of, thinking of situations where sometimes the patient, unfortunately, their pregnancy is not thought of as being primary and whatever else is going on, that we can then accompany that patient with this mobile unit
Yeah.
no matter where.
Yeah, I think that that's definitely possible. I will say that patients who are not in labor generally have fetal surveillance going on, which is a different level of monitoring. So someone might be written on a 30-minute tracing queue shift, right? Unless there's really something else going on, and I don't know the specific situation that you're talking about. So, but I'm just saying that for most antepartum patients, even the ones who have pregnancy concerns, if you're on the antepartum unit, that means we're not worried about you enough to need continuous heart rate monitoring. You would be written for a schedule, and then certainly if something is worrisome, that would be extended as needed.
Okay, we'll talk about it later. Thank you.
Okay.
Thank you.
Thank you. Any other questions or comments? Just one other question, I guess, is related to the interface with Epic and how that information is kept in the permanent record, so to speak. So how does that all, how does that all work?
So the systems of record are going to remain Philips and Telespace and Epic. This pulls information from Epic and from Philips, but it does not live permanently into the record. The colors don't go into Epic, but it pulls information from Epic to. Can you go to the next one? So in the lower right, you see there's a labor curve. So if an exam happens, that will be entered into the flow sheet, and it will pull the flow sheet into this, and it will actually give a prediction of how someone's labor curve is going, and whether or not you're kind of going along as we expected, or maybe falling off the curve a little bit.
So it may not be available to the Epic record, but this independently can be sought after. I mean, you can see what happened if someone wanted to see what the curve was like during this phase. They could pull it up after the fact, postpartum.
Yeah, we would have to go to Philips to see that.
But it's there. It's discoverable. I could use that word, but anyway.
It doesn't. This doesn't say.
Yeah, the actual Wendy's really led this, but we've been good partners. I would think the whole way.
Oh, excellent partners. Thank you.
It's no. It's Philips is where we would go back and we'd look at the actually waves themselves.
Right.
Epic is feeding this the data on
Right.
who the patient is. When she said flow sheet, that's an Epic field on where the patient's progressing, and it all kind of merges into this to give the patients. This is like a visualization of what's happening in real time for the
Real
patient.
time.
And that's how I'd think of vigilance, but the systems of record maintain the same. So if we had a question for after the fact for an RCA, we'd go back to Philips and we'd go back to Epic.
Right, so if you're analyzing what happened to this case, then you'd go to Philips and you'd be able
Yeah.
to look at this curve. It wouldn't necessarily be an Epic, but you'd be able to see it.
And when you tell
It's
me,
not
if
just real time, in other words. It's
tell me if this works clinically. For
analyzed for QA purposes, for example.
Yeah.
I mean,
I don't think there's any new information here that's not available in those other systems. It is a flagging system, and that's what this is my understanding. Does that fit with?
Yes.
Yeah. So there's not independent data that's available here that wouldn't be available in other systems. It is a clearer way to look at something to spot early problems.
other questions or comments? Otherwise, fabulous work. Amazing.
Thank you.
It'd be great to see the outcomes because, it'd be wonderful to see how it's improved both the fetal and maternal mortality, morbidity. It'd be really great to see that data. Okay, let's move on to MetroPlus.
Good morning, everyone. My name is Sanjeev Shah. I'm the Chief Medical Officer at MetroPlus. On behalf of Dr. Boyce, our CEO, I'd like to present the MetroPlus Health update. What's Project Edge? Well, I want to point the board to the bottom left of this slide. We have a core processing system. Every health insurer has to have one. And that's sort of the engine that health insurers use to pay claims, manage the network, focus on member eligibility and access to care. You can see on the bottom left all the way from membership, insurance premium billing, claims payment, utilization and care and disease management, all the way around to healthcare benefits. That's what a core processing system does. Why do we need this transformation? Well, point you to the right-hand side of this slide. We currently operate a pretty antiquated claim system. It goes back 30 years, and this is really perhaps the most seminal development in the plan's history in terms of updating that system. We process over 9 million claims a year, and we really need a system today that's more automated, more flexible. You may have seen the Annals of Internal Medicine that just came out with the American College of Physicians talking about the responsibility of managed care plans, and the major outline here was a utilization management system that didn't impede providers from seeking prior authorizations, more automation, more real-time access to that information. This is what Project Edge will deliver for MetroPlus. So to that end, the next slide, please, we picked for the first line of business to go live, the HIV Special Needs Plan, it is a Medicaid line of business. Well, as you recognize, Medicaid is our largest line of business, but this specific line is small in number, so less risk, but has all the attributes of Medicaid, but also has utilization management, and in particular, has complex care and disease management of a population living with HIV. So the scope is immense, a huge amount of time spent outlining all the requirements for Medicaid, creating all the test cases to be executed, resolving defects, and then most importantly, creating a readiness for our employees to train them all in the new system with policies and procedures as well as desk level top mechanisms so that the full staff across the gamut of the organization was trained.
Is it possible that really you chose this to remind the board that you have the #1 HIV SNP program in the state?
Well, that too, and but as you know, some of the highest viral load suppression rates, particularly at Gouverneur, where
Right.
I'm privileged to practice. So, next, please. So this wave one, which was the special needs plan, obviously there was a lot of planning ahead of time, an RFP for finalists. Health Edge was chosen as the contracted vendor. We conducted design and discovery in 2024, and then, as you can see, all the requirements that were necessary to build the program, begin the training, and we went live December 15th of 2025. We're spending 2026 stabilizing the Wave 1 effort, and Wave 2 is the most important aspect of this, which will make sure the mainstream Medicaid lines of business will go live, along with the health and recovery plan, another Medicaid line of business that focuses on people with serious mental illness and substance use. Okay, I'd like to shift now to Medicare adherence. Currently, the plan spends a huge amount of time on adherence to three particular Medicare STAR measures that are all triple weighted. They focus on adherence to statins, adherence to renin and angiotensin system antagonists for hypertension control, and then the oral agents used for diabetes management, so not the insulin agents. So the goal here is to conduct member outreach because to ensure in these measures, not just the medications are prescribed, but actually dispensed and adhered to. So what you do here is we have pharmacy technicians that outreach to members, outreach to providers and pharmacists to ensure these medications are dispensed. And we've focused a lot of time and attention on that in the last 3 years. And you can see these technicians have placed a huge number of calls, which have therefore translated into improved adherence with these 3 STAR measures, which are triple weighted. So on the next slide, you'll see the year-over-year improvement. And even though these improvements look small, the cutoffs for 5 stars are very small indeed. So you have to have minimal improvements to lead to these massive improvements in star ratings. And so you can see on diabetes, the RAS antagonists, as well as the statins, the year-over-year increases that have resulted from this outreach effort. Next, I'd like to focus on the health and recovery plan. I mentioned that in September of this year, we'll go live with that aspect in Project Edge. So the state has a huge focus on this line of business. The state itself determines who's eligible for the health and recovery plan based on its own algorithm for serious mental illness and substance use. We have about 13,000 members who the state has designated as eligible. And the way the state focuses its attention here is by withholding 2% of the premium. And if you do well in terms of quality outcomes, it'll return that premium back to you. So it's a withhold mechanism that translates to around $10 million of funds that are held behind. They focus on both quality of care, 80% of the score, as well as satisfaction of the membership. And they go across the whole gamut of measures, mental health, substance use, as well as primary care. And there's a disproportionate amount of people in the health and recovery plan also living with HIV, so they're also a focus of attention, in particular viral load suppression. The plans have two ways to earn points for each measure if you achieve the 50th percentile, or they recognize year-over-year improvement by 10%, even though you may have not reached the 50th percentile, to show you're closing the gaps. These measures on the mental health side tie in very much to the Behavioral Health Centers of Excellence, which H&H participates in, along with the two other plans, Fidelis and Health First. A lot of funds are directed to these centers of excellence, so there's a broad overlap of these measures, as well as the value-based payment arrangement that the system has with Metro Plus. So you can see on the next slide that for measurement year 2023, I'm sorry there's a delay, but that's the way the state calculates all these measures that was shared last August. The plan achieved 100% of the withhold, and I think that's an achievement that we'll probably repeat in 24 based on the results that we've seen preliminary, still waiting for state confirmation of that outcome. And then finally, to focus on the RIOs, the plan works with the health information exchanges, principally two RIOs, HealthX and the Bronx RIO. The RIOs are extremely critical entities because what they do is supply the plan with information well before a claim is submitted or received by the plan. If you can see on the bottom of this slide, by the time an admission and discharge and transfer occurs, and if you wait for a claim, it'll be too late to act on individual member outcomes. And so the ADT alerts, as well as the continuity of care documents that accompany these alerts around peri-admission, discharge, and transfer, are critical to provide care coordination. Next slide, please. So we've been working with HealthX since 2022. HealthX connects over 9,000 facilities, serving over 20 million patients across New York City and Long Island. We leverage it for non-H&H sites across New York City, excluding sites located in the Bronx, because then we rely since 2024 on the Bronx RIO, which makes up that gap that HealthX does not cover. Again, for H&H, we receive the ADT transfers directly through our links with the system, but for non-H&H, this information is critical. The next slide, please. This partnership has really been instrumental in unlocking a huge amount of information around these critical care transitions. Again, for H&H, we receive it directly from the system. And to look at the impact of the ADT alert, the next slide shows you on a couple of measures pointed out on the right-hand side, FUA and FUM. These are measures of people presenting to the emergency room, FUA with substance use as the principal diagnosis, and FUM presenting with a mental health diagnosis to the emergency room, mind you. Not an admission where you have some time to digest the admission and figure out what's going on. This is somebody who comes to the ER and is then discharged from the ER. They're not admitted. And how do you follow up with them? Well, the ADT alerts are critical in that element, and they allow the plan to conduct telephonic bridge visits with members. And we've seen that these bridge visits are critical because we've seen through our data that once a bridge visit is completed, the individual is 1.5 times more likely to engage in longitudinal behavioral health care services. We've seen a significant increase in our performance, as you can see on the right-hand side, with both FUA and FUM, and that translates into the HARP withhold that I mentioned earlier on, as well as both the system and the plan's performance with both H&H and non-H&H ED visits. Happy to take any questions.
I was trying to understand on that last one, how for example, when you look at ADT data or any data like that, how is it different from what H&H sees, or are you developing, like, for example, different ways of using the data?
No, so say on an ED visit, we get that information comes to us directly through feeds that we've established with H&H. We don't, I mean, H&H participates with Healthix and the Bronx Rio, but we don't rely on that information because we've established those linkages long-standing. But Healthix and Rio really helps us with non-H&H, so the admissions that occur to Bronx Care or to SUNY Downstate or in the future to Maimonides that we're chatting on about ahead of the meeting. All those admissions, Mount Sinai, NYU, all those come in through Healthix or the Bronx Rio. They're as real time as you can imagine because there are sort of notifications. They come across the system. We then use that to determine the discharge occurred and immediately conduct the outreach to say, where are you going to follow up after the ED visit for both substance use and mental health? So they're no different from what we receive already now, Dr. Pagan, from H&H, but it's essentially strengthens the mechanism through the RIOs for non-H&H sites.
And that time frame difference, we have staff that almost instantly can reach out. In other words, because you're getting the earlier information, we have people that act on it immediately, or
Yeah,
is
so
there
for
a
example,
capacity to do that?
so
with
for
the
example,
additional-
at H&H itself acts without the plan. You can act with social workers in the emergency room.
Right.
But, and we do that right now, and there's a whole initiative now to really strengthen that connection in the ED before the person leaves. But, and it by all means may be occurring at Bronx Care or Montefiore doing the same thing. This is really a fail-safe mechanism. If it didn't happen, we, the plan, can reach out to that individual in realish time as possible for that to take
There's
place.
a possibility that the claim might even.
Well, the claim will
be
come
very
in a week, 2
long
weeks,
after.
30 days later. It's too late by that time.
And
The
these are
FUA and
sensitive-
FUM measure requires you to act within 7 days of the event. Too late for
Right,
when a
so
claim
we
arrives.
heard us on that factor. And these are sensitive areas, so question would be, whether it's Healthix or Shine or whatever, the information can be transmitted. Is there an issue about patients, HIPAA issues with the patient having to allow for, for permission on those, or is that automatic when they sign up with our plan, or how does
Yeah,
that?
the TPO arrangements the plans have with patients when they actually enroll does allow for the plan to act on the patient's behalf. There are extra sensitivities to substance use
Right,
with the
that's
42
two
CFR
examples.
regulation that's federal. So there are some limitations there. But when we do the outreach, we actually often say, we hear you're in the emergency room. Can we help you with anything you might need? We don't necessarily refer at that situation to whether you were there for substance use or mental health or for a non-SUD mental health related condition. But the whole purpose of the outreach is to essentially begin to help them create a bridge back from the community back to the clinic in that instance.
Perfect. Any other comments, questions? Okay, great. Super, great report, thank you. All right, let's move on to IT, Dr. Mendez.
Right. Kim Mendez here, CIO for New York City Health and Hospital. We have, in our update, we have 3 focused areas. I'm actually going to hand off to Dr. Michael Boughton in a second to do the digital health and MyChart, which is our patient portal update. Also in the report, you'll see a year in review for data and analytics, artificial intelligence, and our innovation services. I did want to pause for a second to say that we have said farewell to Divya Pathak as our Chief Data and AI Officer, but I will have her raise her hand down here, Amu Minion, who is our interim chief. So just to bring that to the board's attention. In addition, as you know, we started our Unprint initiative last year. And I will say overall, and you'll see this in the report as well, we've saved 16% in cost as well as a reduction of 16%. That's across the entire enterprise, and we can certainly. I will also just say that here at central office we had a 30% decrease. So that was we were the vanguard, and we're moving forward. So next year will be even better. So Mike, let me just hand off to you for a general overview of where we're at with digital health and MyChart.
Thank you very much. So a little over a year ago, we presented an expansion of reaching out to our patients, how they wanted to be reached out to, which is via text message. We allow email, we allow through communication through MyChart, a little bit through the phone, but patients really wanted to be reached out through via text messaging. And this is the results of that for 2025. We had about 1 million patients confirmed their visit. That's good. That lets us make better use of that time frame from a physician's end. But I'll really attract your attention to those, that second line. About 100,000, they told us it was canceled. That allowed us to make better use of that time, to reschedule another patient for that slot, or just let the physician know and the nurses know that there's not going to be somebody coming in, so they can optimize their time throughout the day. That next line down, FastPass, is related to a post cancellation. What this is if you cancel, if an appointment suddenly opens up, what you can actually do is send out notifications to a whole bunch of people that are on a wait list, get them to sign up for that slot. 13,000 of those were done just through this SMS pathway. There's other pathways to get them scheduled, but just through this pathway. And the last thing I'll say on this is the no-show rate when you do confirm through text messaging is an absolute difference of 6% lower. So it's a really big difference. Our patients want to be reached out to this way. We're not forcing this upon them. These are the patients that are opting in to be communicated with through text messaging. You can go to the next slide, please. In order to make our program work, the physicians, the nurses, everybody needs to be comfortable with this. And so we go on site and we actually train people. We sit with people and we sit next to them to let them know how to do video visits, to let them learn more about MyChart so they can be better ambassadors to our patient population. If you can go to the next slide, and we've done that at all the sites you see. We talked a little bit about some of the things we're doing with making MyChart more useful for our patients during previous board presentations. What I'll show here is the proof of that. All of that effort over the past couple years, the MyChart activation rate, which is what you're seeing in that with the little blue arrow pointing to it, we are 2% better than the Epic average nationally, and compared to other safety nets, we are 7% better. This is, we've put a lot of time and effort in this over the years. We started quite low. We were in the bottom quartile, and we've come up incredibly, where we're now significantly above average. And I think we all should be very proud of this. And this is a partnership between certainly IT, but very much ambulatory, inpatient, ED. This is because it's a useful tool to our doctors, our nurses, and our patients. If you can go to the next slide, please.
So is there any scenario where in responding to MyChart messages, they could go to text directly? So it's such a generational thing. The young people are so uninterested in anything that requires, going to email, checking things. And, if it must be technologically possible.
Yeah.
I don't know it would seem like if I agree that you can text me, I don't really see why there's a HIPAA issue. But it would make if it could be done, it would make communication with patients so much better.
Yeah,
especially young patients.
I think you hit it on the nose with the concern around texting. We're very careful about what we text out, where there's no patient-specific information in it. We're not saying you're coming in for this reason. We're just saying there's an appointment available that you can reschedule, and then everything else actually happens within MyChart, which is kind of like a seamless link between the text going out, where the patient gets it on the text, but then it actually opens up. You're giving them a link where it opens up in MyChart where you can do that one-on-one communication that goes from the patient on the MyChart side to the physician in basket. But I think the short answer to your question is that just communication simply via text has not been deemed to be regulatorily allowed at this juncture. And our pathway involves sending links that get you to MyChart, which is the way to do it.
Right.
So that's
Yeah, it's imperfect.
Yeah.
We're basically compromising people's ability to talk to their doctors on a theoretical risk that somebody is having other people read their phone messages.
You are
right.
correct.
Because most people password their phones, right? The idea that what we're doing is, and again, it would only be with permission, right? But it is such a common complaint of patients that they, have to enter into the MyChart environment, right? For some people, I know that seems ridiculous, right? But people forget their passwords, and then you have to do the authentication, and it just means that people don't get, and it just annoys me that we're saying that, well, it's okay that people miss communication because congratulations, we're really good on HIPAA.
Yep.
What is it in the story that really matters?
Yeah.
You would think what people would feel really matters is whether or not people can talk, again, with their permission. I'm not talking about sending messages that people are not willing to get. But no, you can't. I can't consent. I'm not allowed to consent to you to send me a message directly, because what if after I consented, I somehow gave my telephone to someone else and my password to my phone so that they could check my messages?
I think you are correct that we have an imperfect system that we're trying to make the best of the regulatory environment within. One of the tacks that we have taken is allowing Face ID. So if you pick up your phone for MyChart, I don't put in, when I use MyChart as a patient, I don't put in my password anymore. I just use Face ID and it logs me right in.
Yeah.
Now, is that perfect? No. Is it as easy as text messaging? No. So we're trying to make it as easy as possible, but you are correct, it is imperfect. We talked about how we got to being, 7% above the Epic average, or 7% the Epic safety net average, and this is part of it. We have a very diverse patient population. Their primary language is, very disparate across our system. We're doing which hospital has which patient population, and this is I'm proud of. We meet our patients where they are. So the 3 new languages we have added to the list that you see below here is Wolof, Urdu, and Albanian. We are the national leaders with how many languages we have available in MyChart today. There's nobody that has more of us than us, and I think this speaks to our values and what we do here at New York City Health and Hospitals, and how we've gotten our population to be as engaged with the tools that we have as they are. I think that's it. I'll be cautious, judicious with time. This is kind of just a summary of how we've gotten some more of the engagement. We now allow rescheduling through MyChart, not just scheduling new visits. This is incremental progress on some of the stats you've already seen. And with that, I'll close.
Yeah, thank you very much.
I have a question following up on the earlier conversation on texting, which is like, is the issue like internally, like we decide for risk management that we cannot do it, or is it CMS saying, if you ask them, they'll say, no, you cannot do that. You can do this, but you cannot do that. I was trying to understand where the boundaries are, and whether, because many of these things, I always feel like we're the largest public system in the country, so we should be able to call CMS, hey, Dr. Us.
I think this is
there and say, hey, have you considered this?
I agree. It's probably a good opportunity for advocacy. Our setup here is not dissimilar than NYU's setup or Mount Sinai's setup. I don't think anybody has leapfrogged us and are going directly to text conversation. But from an advocacy standpoint, I think this could be an example where the regulatory framework is potentially doing more harm than good.
I think it is. I think, as Mike is saying, it would be the way to do it is what Mitch is getting to, like have people sign up for it and have it be in a separate place, because it's important to remember, if you send a MyChart message right now to me as your primary care doctor, it can go to a pool, somebody else could answer it. There's also a message that comes up about connecting you to Virtual Express Care, which 1 out of every 5 people or so choose to do. So there's all kinds of things that you get by using the MyChart messages as they're intended. That said, I have a patient right now that I'm trying to discuss his MRI with him, and we just can't connect. I keep calling him, and I say MyChart, like, can you call me back? But so it is imperfect. And if I could text him, to Mitch's point, he would love to get texted. He's a young guy. It'd be perfect. But for everybody else, I think it's we'll have to find that balance point between how people are engaging us now with the tools the teams have built out. Like Elmhurst has a very advanced system doing pools versus the patients that want to do it that way.
I think in the community, people just go ahead and text their patients. I think that's just the reality is that because everybody thinks it's stupid, right? So, I mean, you know, it's, you know, to the way I think about it in government, part of, you know, the challenge of government is it creates silos. And there's a group of people who live for privacy. That's their thing. They're privacy people. And anything that sounds like, you know, could, you know, endanger your privacy, you know. I mean, I think you even added in my chart now, it isn't enough to know your password. Don't you also now do separate authentications?
Yeah, so
So
we have
now we're doing double, so it's not,
Exactly.
it's worse than it used to be, because everybody is pushing, right? So now it isn't enough to just know your password. Now you have to know your password, and then it's gonna send you a code, right, that you then have to put in, right? All to communicate with your doctor when everybody else in the universe is texting. But, you know, the chance of getting the people, because you raise an issue like this, CMS will send it to the privacy people. And the privacy people, oh, there's a risk. And, you know, people have all sorts of scenarios in their mind about the worst case, right, scenario. Is someone, your mother gets your phone, and then, which, you know, again, it's possible. Everything has a benefit and a cost. And it's just, this is so far from worrying about the theoretical. But I think in the community, everybody just checks their patients.
I think the positive spin is, despite all of that, about 66% of our patients do use it.
Yeah.
So,
Well, older people. I think if you're part of the email age, it's not so terrible, right? It's how you do everything else.
Yeah.
So but the younger people who think, you know, email is, you know, boomer life, you know, they're not going to do it.
Well, it's not a one size
Do
fits
not take
all.
these things literally. These are just generalizations about the community, not anything we would suggest or do, just so you're
Right.
aware of that for the record. But, no, I agree with your point, and you are correct what the community does, but at some risk, because they are sending on a text. I think it might make sense, though, to pursue a little further, as Jose was saying, maybe with legal, to look into being able to give the proper education to people with respect to what this means when we're able to text you, and have them sign off, and maybe we could look at some pilot of that, because I think you're right. I think that is basically the case at this stage. So.
I agree about us advocating because we are the largest system, and I think there's a path forward where whatever the regulations are that are barriers, that maybe we can, you know, have maybe some legislators would take it on as well and create language that fits the need for people to text.
Any other questions?
No, we're done. Thank you so much.
Thank you. All right.
All the rest is in there.
All right. And Dr. Sineas?
Thank you. Good morning.
Best for last.
Thank you. But my mother checking my chart. That is good. I'm like, Right, good morning. So for the nursing report, we have a few highlights. First and foremost, we've completed the care delivery daily management training at Kings County, where we've trained over 1,000 nurses and support staff on communication, escalation, and also back to basics of nursing practice. Next slide, please. And that's a photo of all of us celebrating our great work. Also, we have started a central office focus on community impact. That's so where nurses can also join us. So we're happy to have launched the Central Office Breast Cancer Work Group as well. Next slide. When it comes to nursing excellence, we continue to do amazing things across the system. This past year, we had over 500 nominees for the Nurse Excellence Awards, where we recognized 35 nurses. Our keynote address was made by Dr. Ina Williams, who's the Chief Nurse Executive at Yale New Haven Health. Not only did she deliver an inspirational keynote, but we also presented her with the Josephine Bolus Nursing Champion Award by Michael Bolus. I want to thank Dr. Katz for his presence. Next slide. That's all of the winners. Next slide. As we continue on our nursing excellence journey, we implore all of our sites to apply for the Beacon Award for Excellence from the American Association of Critical Care Nurses, which is a prestigious 3-year designation. Next slide. You see a list here of all of our sites. We have Queens Beacon Gold initial designation, Metropolitan Beacon Gold redesignation, Elmhurst Beacon Silver redesignation, Elmhurst Beacon Silver redesignation, and lastly, South Brooklyn Health Beacon Silver redesignation. Next slide. This is a photo of Metropolitan Hospital. They are among only 24 ICUs nationally to earn consecutive gold level awards in 2024 and 2025, and just 1 in 4 in New York State. So we're really proud of the Metropolitan team. Next slide. When it comes to the Association of Perioperative Registered Nurses Enhanced Recovery After Surgery, they also have a designation which we're really proud of. Next slide. On December 23rd, Queens Hospital announced its designation as a Center of Excellence in Surgical Safety, Enhanced Recovery After Surgery, if you could go back, thank you, by the American Association of Perioperative Registered Nurses. This recognition honors Queens Hospital as the very first facility nationwide to receive this designation. So we celebrated, and it was a wonderful event. Next slide. We continue to promote professional development for our nurses, and so we deployed nurse builders at no cost to our nurses, resulting in over 4,000 active users, really studying for certification, which is the hallmark of nursing practice, which we are proud of. Next slide. We have started a series of pipelines for nursing. So this is our behavioral health nursing career ladder, where we have 8 support staff enrolled in an associates in nursing degree at LaGuardia and Queensborough Community College. This is a grant that we received from Sloan Summerfield Foundation. We have a second cohort currently enrolling as well. We're really proud of them and supporting them to become nurses who will ultimately work at New York City Health and Hospitals. We recently just launched a Med-Surg nursing career ladder as well. Next slide. Our nurse residency program, we're proud to say that we have launched our 50th cohort. We celebrated the event with stakeholders from the Mayor's Office of Talent and Workforce Development, from the New York Alliance for Careers in Healthcare, were also in attendance to join us. Next slide. This is just a quarter of our participants. We've had over 2,000 participants in our nurse residency program with over 90% retention. I'm really, really proud of this program. And that really concludes our report. We have preceptor development where we're training our preceptors, and also a continuance of special fellowship programs for our new nurses as well. Thank you.
Thank you. Spectacular. Dr. Marchand?
I just want to say I'm always impressed with what you're doing with the nurses and their investment, and I love the back to the basic concept. You know, I have a long career of working with nurses, and 13 years that is, and you know, back to the basics speaks a lot, because when people are often updating their skills, they're not looking at the basics, and new things come up in basic practice, and then it's like behind them, especially if they are not necessarily as hands-on as they used to be. So excellent as always. Thank you.
Thank you. And it's interesting because even leaders, we all go to different schools, but are we all speaking the same language? So it's been wonderful to do a full reset, and we're off to North Central Bronx and Jacoby next. Thank you.
Yeah, thank you.
Same comment. What I would add is just simply always impressed with the way you focus on career development at every level.
Yeah.
And it shows. So
Yeah,
thanks.
the retention data speaks for itself. It's spectacular. Amazing work. Any other comments, questions? All right, any old or new business? There being none, meeting is adjourned. Thank you all.
Thank you.
This meeting is no longer being recorded.
This meeting is being transcribed and summarized.